sheet to over there. So what we will do now, because the group is big, if it's a small group, then we can really do a hands-on and you can do it yourself. Now we will demonstrate it here. We will put it on the camera so you will be able also to see it and follow it on the big screen. So the first device that we would like to show you is this bioelectrical impedance analysis. For that we have the Maltron Touch i8. This is the device I showed you. This is the device that we tested in the ICU. And it's one that I think is useful because it fulfills all these criteria. So 8 electrodes, the multi-frequency, and the STAR method with a segmental analysis. So you get the 5 body cylinders. So if you want to use a device, these are the things that you need to ask the company whether the device has multi-frequency, 8 electrodes, so both sides, segmental analysis, and a kind of repetitive measurement on the left, on the right, crossing the arms, the legs, and having a robust mean value that is reproducible. Because otherwise, if you only do it left, only right, you change a bit on the electrodes, you will find different results between nurses, and the intra and inter-observer variability is too great. So this is okay, and we will now show you how to do it. So, patient should be supine position. Patient should not touch both legs, should not touch the bed, okay? Sometimes in obese patients, we need to put a cushion in between the legs to separate left and right. So now we're gonna place 8 electrodes. So, yes, you can do, Andron. So, yep.
The placement of electrodes are on the hand.
Where there is deflection, so you put one here and one just before the knuckles. Before the knuckles.
And preferably in a straight line. And if you have any moisturizing cream, or if there is any moisturizing cream or oils on the hand, you just wipe that off. For our device, we have no exclusion. Patients, you can measure whichever patient in ICU, different conditions, multiple conditions as well.
Okay, so we put 2 electrodes on the right, 2 on the left.
What we do, can you hear me? Yeah, okay. What we do is that we divide the body into 5 segments. So there are 2 arms, 2 legs, and the torso. The fluid accumulation occurs in all the compartments, in all the limbs, and also in the trunk as well. So we need to look at the entire fluid distribution of both arms, both legs, and the trunk as well.
Okay, we need to move on because we have 20 minutes to explain this. So usually it takes a couple of minutes to do the measurement. So we do the same on the feet when there is this and just before the toes, and you put them in a straight line. Now we go to the machine. There are 2 cables, one for the left, one for the right, and they have these clips that are numbered 1, 2, 3, 4, 5, 6, 7, 8. So you start, I would say start with the hand, which is 1 and 2, and you put the fire on top of the ash, okay? So the red on top of the black, 1 and 2. And then you do the same for the right foot, 3 and 4. The red on top of the ash. That's how I remember, you know, for the ECG. You have the sun above the grass for the yellow and the green.
The easiest way,
yeah.
Closest to the red one.
Okay. But this one is not close. So we have 5 and 6, 7 and 8. So you make sure that the connection is okay. And now we can have a zoom on the screen. The cameraman, can you zoom on this? Kilo. 65. Okay. So on the screen, when we go to a new patient, this is the 5 things that we need, besides the correct measurement, the height, the weight, the age, and the gender. No, we will show when we have the results. So we enter the basic data. I'm not sure whether we will, okay. And then the ethnicity and the build, which is normal. You could, if you have a lab result of serum creatinine, you can enter it and the machine will calculate glomerular filtration rate. Okay, so everything is ready. We're using the vascular star method, the segmental body analysis. And now we can start the measurement. Okay, you just need to put something for the name and a record for the EMR.
For the ID, you need to have more than 3 characters, otherwise it won't allow you to go further. Okay, just remain still.
Yeah, but you can show here the screen showed you the position of the electrodes. If you don't remember, it will visualize how to put the electrodes. So now it's processing. This is the measurements from right side, left side, crossing, and taking an overall average. On average, this takes 1 minute, 1 minute and a half?
Yeah, about 45 seconds.
Okay.
What the machine does is it checks the electrodes, the cables, to make sure everything is connected. If there is a problem with the connection, then it will pre-warn you so that you don't make any errors in the data collection. By the way, the machine can store up to 1 million, 2 million patient data. Yeah, no, it's not. It's
Left and right.
left and right side. The red one is to identify that it should be used on the right side. So 1 and 2, 3 and 4 on the right, 5 and 6, 7 and 8 on the left side.
Almost there. Are you okay? Everything fine? Sometimes you can feel a little bit of electricity, a little. No, it's not true.
Do you want him to stay there or do you want to disconnect him?
I think the measurement is done. Now we will run through the screen. So yes, the measurement is finished. So we can release our healthy volunteer, and I would suggest we give him a big round of applause for this measurement. Okay. Okay. So now you can take us through the measurement. So the basic screen is the fluid status. What you see on the right.
The first point we would come is excess fluid, which is down at the bottom right-hand side. If the patient had more fluid, then you would indicate in color-coded. So you would either have, say, red, orange, or green. Green is classified as a normal value. If you were in the red, then of course that would be something to be concerned about. Then we give you a dry weight in case some clinicians want to use that value. You can use it. For us, we look at the fluid status, and then we look at, alongside the assessment, we would look at intracellular water, extracellular water, see how much fluid is in the intracellular water. Of course, you want.
So it's a lot of information, yeah, and it's new information that we are not used to. So if you start using it, you just look at one or two parameters for starters. So the most important one is, as said, the fluid status. This is the plus 10 liters that I showed you in the case with COVID, with sepsis, and this is the cumulative fluid balance. So here it seems 0. And then the other parameter I spoke about is the extra intracellular water ratio, which is 0.7, below 1. This is the normal situation. You should think, because intracellular is 66% and extracellular is 33%, you would assume it would be 0.66?
Yeah, something,
something like that, so 0.7, and you see the extracellular water here is 42. So I think this is within the normal range. Okay?
You have all the references there as well. You've got the maximum and minimum references on the side of the screen as well.
So the second thing, which is important, and I showed you in the study, the malnutrition index, which is based on the phase angle. So the phase angle is the amount of healthy cells, the nutritional status, and here a phase angle is 8.03. We can have the Aspen phase angle, the standard one, and there is the Maltron one, but both are linked to prognosis. So here, phase angle is normal, and you can have, like in a fitness device, the body fat, you can have the muscles over here, like skeletal muscles, so everything you would normally expect in a device that gives you body composition. This is the screen that I showed you in the patient with sepsis capillary leak, where you start from the right edematous and you de-resuscitate and you go back to the normal situation, just to visualize. So you could start with this on day 1 and then you follow up and then you will see if your patient becomes edematous and if there is need for de-resuscitation. And this is the graph, the evolution of the extra cellular water. If it would be high and you do ultrafiltration, you can see the trend. So moving on, this is the separation between left, right, and the trunk in order to find out if there is one place or area where there is more fluids. Like, for instance, if it would be pulmonary edema, you would expect the trunk to become higher. Here, of course, everything is normal. But these are the things. This I showed you also, that you can go from the different to the left, to the right. Yeah, you still need to change left and right. Yeah. Because for me, the left is right and the right is left. Yeah.
Yeah.
For the trunk will then be proportionally.
Let's put it this way. The case examples that we've seen, X-rays and ultrasound have confirmed them to be accurate.
And you showed in the study I showed you, and other studies, there is a link with extracellular water and extravascular lung water. So, I would never treat the machine or the numbers, I would treat the patient, but this is just one monitoring device in a multimodal setting. So you have the clinical, you have the laboratory, you have the X-ray, the ultrasound, you have this, and yeah, but you don't know where is the fluid and whether there is pronounced capillary leak, which may be an indicator of poor source control, and an abscess or something that needs treatment. So it gives extra information, and we need this information to avoid causing harm to the patient, to do the right thing. This? I would use it in a patient where we discussed this morning that is in shock, tissue hypoperfusion, and then all the things related to organ dysfunction. You could use it in healthy patients, but then you're going to have healthy screens, which are not very meaningful. in any patient where you have a therapeutic dilemma. A therapeutic dilemma is a situation where, at the same time, you can do two treatment options. I could give fluids to improve cardiac output and kidney function, or I could remove fluids because there is pulmonary edema and I would like to save the lungs. Every time you need to choose to support the organ that carries the highest risk for killing your patient, which on day 1 could be the circulation, the heart, on day 2 maybe the kidneys, and on day 3 maybe the lungs are flooded. So it's dynamic. So therefore, what we did in the COVID patient is measure every day, and you see the evolution. And it helped us to decide when to de-resuscitate or when to consider there is an issue with fluid accumulation. Not just this, but the PF ratio, the lung water, the intra-abdominal pressure. So it's not one size fits all or one device that solves all our problems, but it's extra information. Sorry?
Does it measure the intra-abdominal or just give us an idea there's some problem in that?
Well, it's in the trunk. So the cylinder is from here to here. So it's the chest, it's the abdomen. So if you would have intestinal edema and a lot of fluids in the abdomen, it will capture it. And then it fits with the clinical picture if there is distension, increased intra-abdominal pressure. So we just need to use our brain and continue thinking and trying to understand what is happening. But taking you through the screens, the next screen is the intra-extravascular fluids. So if you have fluid accumulation and you would like to know where is the fluid, it can be intracellular, extracellular, but it can also be intra and extravascular. And there you'll have to ask Anjun how it calculates plasma volume, interstitial fluids, and hematocrit. But I think this is an algorithm that lays behind and gives this kind of values.
This is not just a BIA device. It has other technologies within the device that allow us to assess intravascular and extravascular, completely non-invasive. So we look at frequency domain, spectrum analysis, AI integration, and other technologies within the device. And just going back to your question about, I can see the edema. The objective is to detect this much earlier before you can see it. You don't want to be waiting till you can see it because, yeah, like you say, there's no point. So with this, you can separate the edema, the start of it, when it's starting. So if you do it regularly, you can see the evolution of the patient, whether they're deteriorating or getting better with all your interventions that you're undertaking. Yeah? It's 2 minutes test, although it took a bit longer. The testing time is 2 minutes, and you get a nurse to do it as frequently every day on all your patients. So you get, and this will store all the data, so you can go back, get the patient data, change the weight if you need to, and 45 seconds later you get additional information.
Hello, I have a question. For burn patients, is it helpful to recognize the compartment syndrome? Because we have many patients that come in with fluid overload and we have to do sclerotomies for them. Is it helpful to tell us when to do it and when not to? Because we usually do it prophylactically. So,
absolutely.
Yeah, is it helpful? Does it show us this device?
Mm-hmm. Mm-hmm.
Well, it depends where the burns are and whether you can put the electrodes.
Well, we have dry electrodes, the ECG type of dry electrodes. You can attach those, and you can, as long as we pick up the signal, you should be able to, the device will work perfectly. Yeah, absolutely. Everything you saw here, it'll show that.
It'll show the water content, but not the pressure. No, the pressure not. But maybe, I don't know, and I'm not aware of any studies, maybe if a compartment is under pressure, it will affect the reactance, resistance, capacitance,
Well, of course it will,
impedance.
yeah.
But I don't dare to say it will show this or this or this. But yes, it'll show fluid accumulation, especially in burns. But if you have circular eschars on the limbs, I think because they are fluid overloaded, may be good to do preventive. Also, if you have circular eschars on the abdomen, because otherwise you have abdominal compartment syndrome. But then you can measure the abdominal pressure, which is easier than compartmental pressures. Yes, please.
If the patient is on any mechanical support, like intra-aortic balloon, like ECMO, it will interfere with the results
No.
of this machine?
No. You can, there is no exclusion of any kind of patients that we've experienced. We do babies, we have a device for babies, and they can be on ventilators, and we've done multiple tests on babies on ventilators and adults, of course.
And the cases I showed you, there were two on ECMO, the COVID patient and the lady with the transplant. They were on ECMO all the time. And you see that on ECMO, initially there is this large inflammation reaction capillary leak. And then when we put CVVH, we can reduce the fluid balance while they are still on ECMO. So it captures the change in what is happening to the patient and what we do as a treatment. So I would say yes, it would also work probably in patients with other assist devices.
Yeah.
Sorry? High frequency oscillation ventilation? Yeah, one of the patients that I showed you was on percussive ventilation. Not oscillation, but percussive, which goes up to 700 per minute. No, normally should not, no. Okay. Also not pacemakers or something. But for time's sake, we have to move on. I'm just quickly going to show you the screens. This is the one on the dialysis, where you can put before and after. The machine will calculate the difference in volume, and it will calculate, because of if you put the flow of the dialysis, like 400 ml per minute, how long you have been doing the dialysis. Before and after, it will calculate KT over V, and you can also have isn't that, no, here is no screen. Then the next screen,
That's the
which
GFR.
is, okay, the GFR. This changed completely. It's the first time I see it, so I don't know. So
Okay.
it helps you classifying the CADIGO criteria,
Yeah.
or acute also?
Different stages,
acute or
yeah,
chronic?
yeah. And this is our own proprietary formula. We don't use Cockcroft, MDRD, or EGFR. The reason why we don't, we already measured some of the parameters. So just like KT over V, the volume is already measured, so therefore we give you a much more accurate assessment of kidney function compared to, say, Cockcroft or MDRD. They're based on healthy population. Renal patients or diabetic patients are not healthy, so therefore you should use the formula that we have, because obviously we're measuring other parameters which are taken into consideration.
Okay, and then there are other screens like the minerals,
That's
the,
a new
the
one
bone, the bone density, if you would like. This is the BIVA, I think.
Yeah.
So it's also interesting because on the left, it's like the other screen where I showed you edema and the normal situation. So it gives you information on the body cell mass, so the catabolic state, and there you will say, I could have shown a patient with sepsis that becomes catabolic with a decrease, and then he becomes fluid overloaded, and then you get him back to the normal situation with the nutrition and things. So you can actually quite nice monitor.
Can I just add, the purpose of this device is to measure dynamic changes that are occurring as the patient is being assessed. Yeah, it's not an estimation or anything. Whatever you do, whatever happens to the patient, is measuring that and is giving you that early warning. That's the purpose of our technology, and therefore you get real-time information.
Okay, this one is...
This is a heat,
new as well.
heat map. Yeah, that's
Okay,
new.
so we just wanted to show you, it takes 1 minute, you get a lot of information, maybe too much information. So what we use at the bedside is the volume excess, extra intracellular water, the phase angle. Only with those, they are linked to prognosis, and they can help you to guide the treatment and de-resuscitation. Okay, so now I would say we move to Professor Monet, who will show you the passive leg raising. And will you be the healthy volunteer again for the passive leg raise? We have the same volunteer? Okay. So can you come again? Where are the representatives of the company ATC? Where is everyone? We need some help with the bet. Because I don't know whether we can do a complete passive leg raise mode. You think? Okay. So now, no, now it's good. We are so, yep, well, okay. Can you help us and give Professor Monet the microphone so he can explain to the audience what he is doing? No, here for him. Is there someone from GE or ATC?
So, we will perform passive leg raising. As I told you, you cannot do that just by measuring blood pressure with the bedside monitor. You need to estimate cardiac output in any way. And here, as it's the only device we have, we will do that with echocardiography. And as you know, velocity time integral measures stroke volume, estimates stroke volume, and so we will measure the relative changes in VTI, in stroke volume. We do not need to measure cardiac output, I mean with the surface of the root of the thoracic aorta, no need, because the proportional changes in velocity time integral will reflect the proportional changes in cardiac output. So if VTI increases by 20%, it means cardiac output has increased by 20%, okay? So you just have to measure velocity time integral. I don't know if many of you are used to do that. So for the moment, thank you. So for the moment, I will measure velocity time integral at baseline. So here with this device, there is an automated measurement of VTI, you see. So I take a 5-chamber view, likely you recognize it, and the sampling window, you see the caliper is
moving.
It's just below the aortic valve, usually 1 centimeter below, and you see that the VTI automatically measured. If I keep it as stable as possible, is roughly, yes, it's not, I don't know how many cycles are, so it's around 23, let's say. But you see when it moves away, it decreases, of course. So let's say it's 23, for instance. As I told you, the best way to perform passive leg raising is that you keep your hand here and someone else performs passive leg raising. It's very important that at the beginning the patient is in the semi-recumbent position with the trunk at 30 or 45 degrees, like here it's more at 30. And now I will ask Professor Malbrain to lower the trunk. You see I keep my hand here and now increase and elevate and elevate the legs.
Elevate the legs. They're coming. Legs are
No,
coming.
it's okay.
Yeah.
So it will move me away from the bed as much as possible. You cannot move it more?
No.
Okay, so it means that I don't like this automated measurement, but yeah, but it's too late. We should have
So
done
this
that at the beginning, so keep
should
it
be
in
like
the
that.
automated way. And you see that just lowering the trunk has increased the VTI. You see, now it's 24, 25.
You should never do this because it may create an adrenergic effect and increase the blood pressure. Okay.
So here, as it's not possible to use the bed for elevating the legs, they do that manually. Usually you should do that with the automated motion. And so
There's a
yes.
drop in VTI.
There was a drop just by moving the trunk, you know, by lowering the trunk, but now, no, can you keep your, yeah, down. I will try, no, so no. I should have measured it manually because you see it's not very, but anyway. Should have increased. Okay, no, so it should increase, but again, the legs are not that highly elevated. 2 points, you see that this automated measurement of VTI is not that good because the caliper moves always, and so having an average value is not very easy. I would prefer a manual measurement. With many of the electrical beds, we need to first lower the trunk and then elevate the lungs. You cannot do all in one. There is a Chinese bed, by the way, that does everything all in one. It's called the passive leg raising bed. Just lowering the bed increases VTI in very fluid responsive patients, because just by lowering the trunk, you move the splanchnic blood volume to the heart. And then if you, in addition, elevate the legs, you increase cardiac output even more. Do you understand? Which tells you that a large part of the effect comes from the splanchnic compartment. It's the reason why you must start from the 30 or 45 degree position, because if you start from the flat position, you do not move the splanchnic compartment and it's less sensitive, first. Second, it's important to use the electric motion of the bed to elevate the legs. Otherwise, you can create some, you know, sympathetic stimulation just because you wake up the patient just because of pain. And then it may create some false positives. So the best is to do that with the remote of the bed. Third, the easiest way is to use a continuous measurement of cardiac output. You can use pulse contour analysis in patients with an arterial catheter. You can use a bioreactance because you don't have to do anything to perform the measurement. If you use VTI, as you have seen, it's not that easy, because you have to keep your hand exactly at the right position and measure VTI, relative VTI changes, and you're never sure it's not an RN measurement. But if you have echo only, it is possible. You understand? Questions?
Why not to use, measure the VTI at the start by drawing it and get the one, then we do it after that. And the second question is, what's the time limit? Should be done within 1 minute?
It's a very good question, thank you. It's not a problem of the time limit. It's more than if you do the measurement, leave the room and come back. No. You decrease the precision of the measurement by keeping the caliper exactly at the same place while moving the patient, okay? You increase the precision. You decrease the least significant change, okay? In this way, the precision is better, and so you have the right measurement.
Let's check the VTI now,
But
and then
so we can
because
check,
the
but
patient is now in the uncomfortable. So ideally, the legs should be 45 degrees up, and it also should be horizontal.
So, we will do it in the average.
So now we have 22, 23,
But you
24.
see, it's not a passive leg raising, it's more a Trendelenburg maneuver, but
Yep. But Randlenburg, in the old days, has also been proposed before we did the
It-
passive leg raise.
Yeah, it is. There are some studies with it, especially in a prone position. But again, the best way, I think, is to do a manual measurement, because here you see that automatically no, you don't see that, but the caliper moves automatically out of the... You see the problem with this automated measurement? You see the sampling window? But you see, it replaces itself always. That's why it's hard to have an average value. But anyway, okay?
Okay.
So I would prefer a manual measurement at the beginning. Then someone else, I keep the probe exactly here, move the bed, and then do the measurement again with the right positioning of the caliper. Of passive leg raising.
Yeah.
The effect appears within a minute. Within 1 minute.
Oh, we can
It
see
appears
it
in
instant.
It
If
appears in 20 seconds, okay? But after 1 minute, in some patients, it decreases.
away.
Okay. So that's why it's good to measure it rapidly after it reaches the maximum. You had a question, yes?
How much increase in the VTI you have to consider as significant increase?
Good question. Passive leg raising is positive when cardiac output increases by more than 10%. So for VTI, it's the same, of course. Cardiac output by 10%, VTI by 10%. You understand?
But the least measurable change with VTI, because of
Is
the
10%.
drawbacks, is 10%.
Except if you keep your hand on the patient, then it becomes 5%. So then it's more sensitive, you understand? That's why you have to keep the probe here and not leave the room and come back. You increase the precision of echo.
Cardiac output, the increase in cardiac output.
The pulse
Pulse.
rate?
Graph. Or
What do you call pulse? Pulse?
I mean by the monitor, by the cardiac monitor. Any parameter can I use to detect the change in the cardiac output?
Yes,
Which?
Yes, you
on
can,
the
if-
bedside monitor? or-
well, if you have, for instance, an arterial line connected to a pulse contour device, is that what you mean? And you have the arterial pressure?
Ordinary monitoring by the pulse oximeter. Any rough is. But I need cardiac output. Any parameter can I use to detect the
The
change?
best is cardiac output. The best is cardiac output, okay? So, as I said, if you have a pulse control analysis device, a Pico device, a Vigileo device, etc., as you know, you have cardiac output that's displayed and changes from second to second. It's a continuous measurement. Then it's very easy. You don't have to do the measurement with echo. It's the best one. Not only it's continuous, but in addition, it's very precise. Pulse contour analysis is very precise. The smallest change you can detect is 1% compared to 10% with echo. So it's much more precise. Or the patients don't have pulse contour analysis, but if they have, that's the best way to perform either passive leg raising or PEEP test or end expiratory occlusion test, always. So that's a good question. Other questions?
Okay. You could also PVI, or if you have...
Yes, also. Another way to assess the effects of passive leg raising is to use the amplitude of the SpO2 signal. You know that some devices, I don't know if you have it here, some devices measure the amplitude of the SpO2 signal, which is
Doesn't
called
give.
the perfusion index. You know that? Some people use it as a quality index of the SpO2. In fact, this perfusion index reflects the amplitude of SpO2, okay? PI, perfusion index. In fact, it quantifies the pulse of SpO2. And of course, the pulse is related to vasoconstriction, vasodilation. You all know that in vasoconstricted patients, the SpO2 signal has a small amplitude. But it's also related to stroke volume. What makes the pulse of SpO2 is indeed stroke volume. So we showed that if this PI increases by more than 10% during a passive leg raising maneuver, it means cardiac output has increased. You understand? So you just have an SpO2 signal. PI is automatically measured. And if it increases by more than 10%, it means cardiac output has increased by 10%. Then it's, if confirmed, that would be excellent because all the patients have an SpO2 signal. The problem is that in some ICU patients, the signal is very unstable because of vasoconstriction. And patients with atrial fibrillation have an unstable signal, the same. So for the moment, you have to exclude some patients with unstable PI values. But if you have a good perfusion index value, then the relative changes are helpful for assessing the effects of passive leg raising. Okay.
Okay, so,
And the end expiratory occlusion test as well.
so you don't necessarily need a cardiac output monitor.
Then
so can
you
also
do
have-
not need any cardiac output. And
Also
especially in the
PPV, I would say. If you have PPV
And
and
the
you
same,
see it's dropping.
as I said in my talk, during passive leg raising, if PPV decreases, okay, by more than 2 points, the test is positive. And again, just an A-line, no cardiac output monitor. You need an A-line for PPV. But it's a surrogate of cardiac output. It's not cardiac output, but relative changes in cardiac output are measured by these surrogates.
Okay, so now we move on to the Vexus, unless there is a burning question for the passive leg raise.
Who knows Vexus? You know? No one else knows
The
what
Vexus
it
score,
is? Vexus
venous
score, you know?
congestion by ultrasound, so to look at venous hypertension.
So the idea is to assess the venous congestion, okay? To look at the veins in the abdomen to assess the venous congestion. And it has been suggested to look at 4 different sites. The vena cava, the hepatic vein, the portal vein, and the renal vein. And depending on the profile of the Doppler flow of these veins, you quantify venous congestion, okay? So you have 4 sites of measurement, and depending on the profile, you obtain a Vexus score, so venous congestion by ultrasound. That's the principle. And there are 4 grades from 0 to 3 that have been described. In one study, in post-cardiac surgery patients, it has been demonstrated to predict renal failure better than CVP. And that's why it has become very popular, okay? It would be a better assessment of venous congestion than this simple CVP because it predicts renal failure better. However, some studies have not confirmed it in critically ill patients. And we are performing a study showing the same. CVP is as good as Vexus for detecting, etc. So not sure it's better than CVP, but it should be a more direct assessment of the venous congestion because you have you're in the vein, you understand? So you see really the venous flow. Third point, it's not very easy to measure in all patients if you're not a confirmed echographist. I think you would agree with it. For the vena cava, it's quite easy, we'll see it. The hepatic vein, okay. Portal is more difficult, and renal, in some patients, is very difficult. So that's another limitation.
Can
Why?
you
So,
guide
okay.
us through the vexus? So you always start with the inferior vena cava. That's your starting
You
point.
start with the IVC, indeed, so you know that. You start from the subcostal view.
We just need to put the camera. Can we do like this? Yep. Okay, perfect. Can we change the contrast?
Here you know the inferior vena cava. I see here, of course, in a normal patient, it's not dilated. It's less than 2 centimeters. I even don't have to measure it. And it varies with ventilation. Can you have a deep breath? Breathe deeply. Oh, yes, I lost it. But yes, again.
Yep.
You see, it is, okay, it collapses with, okay. So there is no IVC abnormality. Then I measure the hepatic flow.
Put some color.
So you see even here for the hepatic flow, here is the portal one. Yes, here.
Yeah. Maybe put some color actually to show. There's no. Yeah, something like that. So the difficulty in the liver is you have 4 structures. So you have the artery, you have the veins, portal veins, the sushepatic veins, you have the portal vein and the biliary tree. So you need to identify these structures. For that you can do with the color and the beating. So we saw hepatic artery. Normally the sushepatic veins, they come from the bottom and they spread in 3. And they should be blue, taking the blood to the heart. And then the portal vein is taking the blood from the gut to the liver, should be red.
So
and it has a
usually,
thick wall.
the hepatic veins are easy to find, but here
Normally.
you see, normally, but here.
Is a very good TAPSE, tricuspid excursions. So the right ventricular function is good, should be above 16 millimeters. So you see when you do real life hands-on demonstrations, it's tricky, yeah?
And you must always test before, and we did not, Manu, but...
No, we are not well prepared, sorry for that. Sorry?
change sometimes from equiprop to the curvilinear. Curvilinear maybe.
You could, yeah, from the cardiac to the curvilinear. You could change the probe and try to see if that helps. So, but you understand, it's not easy to get the right images. Then we're going to do the Doppler. Then we have to interpret and put a grading, 1, 2, 3. And then we need to sum up to make the final decision on venous congestion. So it may be observer dependent, and that's why the initial study by Philip Roland of Vexus was done in cardiac surgery patients, where there was a relation to AKI. So venous congestion, worsening kidney function, AKI, better than CVP. But in subsequent studies in ICU patients, in sepsis patients, they were not able to demonstrate the same prognostic impact. Also, it starts with the IVC, but sometimes in healthy volunteers even, you can have an IVC of 24 or 25. And I'm assuming that these patients don't have venous congestion. Also, in patients who are fluid responsive, you can have venous hypertension, grade 1, 2. Why don't we see any color? Yeah, yeah, okay. That was blue. Yeah. Yeah. Scale. No, that's too much. Oh, oh.
So on the different flows, you have a classification that you must learn. Typically on the portal vein, if you have a continuous flow, it's good. If you have a pulsatile one, it's less good. And etc. And the same, you can try to find it in the kidney. Sorry, but I'm not used with this device as well. Can you increase the depth? Yes. Yes. And here in the kidney, You must find. I'm sorry, but I'm not used with this machine. And you must find an artery and vein. That's good. Okay. It's not very conclusive, huh, Manu, I think, but yeah.
Okay.
Because for the kidney, you must have a good color Doppler signal, which is not the case here.
Xavier, I have some videos from Philip Rolla. I can quickly show them. Can you show the presentation on the big screen? Okay. You see, real life can be tricky, so that's why I asked Philip Rolla, who published the VEXA score, to give us some videos. So on the left, hypovolemic, on the right, dilated inferior vena cava. You can eyeball, you can go in M mode, you can measure it, you can ask the patient to do a Valsalva, to breathe, and you will see the variation. So this is a patient. You can also use the curvilinear probe, like the abdominal probe, subxiphoidal. I think there is some sound. I think Philip Rolla will explain us in his own words. Can we have the sound? There you see the hepatics. So next, after the inferior vena cava, the hepatic veins. So normally you should see three coming from below to up. They should color blue. So the right, the left, and the main. So normal signal is that the flow is away from the probe, so it should be negative, should be blue. And it corresponds the CVP signal. So you have the ACV waves, XY descent. So you see an SD, which is kind of, you could call it systolic, diastolic, and an A wave positive. And this is the grading, so normal, mild abnormality, so the S becomes lower, and reversal of the signal, severe abnormality. This is shown
from
here.
right here, I'm gonna pick hepatic vein,
Put some color.
put color on it, and we can see that this is kind of a police siren sign. It's got lots of red, and instead of our nice little red, blue, blue, we've got lots of red and blue all the time. Take that off, put a pulse on it. Remember, you have to get your venous settings on, just to scale a bit.
So you see
We can
reversal.
right there that we've got a markedly abnormal scan with a above the baseline S wave. So this is a grade 2 hepatic venous tracing.
Okay, so severe hepatic vein congestion. Then we move on to the portal vein. You can see that it's thick-walled, echo-dense, and the blood should be towards the probe, so it should be red. And it's normally like a constant positive flow. And you can see when there is mild abnormality, there is more pulsatility, and when there is severe congestion, there is increased pulsatility, which normally is not the case.
Go out laterally, and we can see that we get actually a better angle on the portal vein. There's a little less respiratory motion. Again, I'll put my pulse wave on it, actually here for fun. We'll put the color on it, and we'll see that even on color,
you see
there you
it
go, it's clearly
oscillating, pulsating.
Portal vein. Here we've got a tracing that's actually got both arterial and venous. I'll adjust it a little bit to focus more on the venous.
So severe portal vein congestion, and then the last part is the kidneys, the tricky one. You just go to the medulla, you see the arteries and the veins. You just put the Doppler on it, and you usually see the arterial and the venous signal together, okay? And we look at the venous signal, which is below, is normally constant. When it's biphasic and monophasic, it's severe.
Intrarenal venous Doppler. So here I'm going a little laterally. I have a little rotation of the probe that is counterclockwise to my hand. I try to get a nice long axis to the kidney. And I put some color on it, try to aim. And I'm aiming for an arcuate vessel or an interlobar. I've got a couple of ones that look decent here. I'm going to drop my depth here to maximize my ultrasound power. And we'll see what we can get from these areas. This is the hardest part of the exam.
You see monophasic venous signal.
So we can see here we've got, it's actually a nice tracing you don't often get to see. Pretty much an isolated venous trace. We've got a little bit of arterial trace in the background, but basically we have an interrupted, what we typically call monophasic, because we usually don't get to see the venous flow above the baseline, but in this case we do. So this is really analogous to your hepatic vein tracing with a positive deflection in what's the S-wave equivalent, which we normally don't see, and then a D wave equivalent, so which is the systolic, the diastolic portion, obviously, of the flow. So again, markers of severe congestion. So this patient here is indeed a VEXUS 3.
So then you need to put everything together, the hepatic vein, portal vein, and the renal vein, the normal mild abnormality, severe abnormality. Based on that, you can have the final VEXUS score, grade 0, 1, 2, and 3. So this is about the VEXUS. I told you the caution is that the initial study is in cardiac surgery patients. Okay, now we can move on to the next presentation, which is about hemodynamic shock pattern recognition. We need to move the pointer from one laptop to the other. Okay. So let's start with a virtual case. In order to understand what is a therapeutic dilemma. So this is the lady with the fecal peritonitis, abdominal sepsis, got already in the operating room a lot of fluids, 3 liters. She's on norepinephrine. She has advanced hemodynamic monitoring. Cardiac index seems okay. Global endostolic volume, normal 680 to about 850 or something, so it should be okay. Blood pressure seems okay. So always during the night, things deteriorate, blood pressure drops, lactate increases, CVP may be high, tachycardic, and the question is, what is the treatment of choice? So more volume, norepinephrine, dobutamine, maybe we don't know. We asked the question to some colleagues at the ISICA meeting in Brussels, and you see the majority is still thinking of the sepsis, the shock, the hypovolemia, and initially further fluid loading. If I would give you these numbers, so a low blood pressure below 65, tachycardic, CVP 15, cardiac index 4.5. Norepinephrine, you would say? Okay. Norepinephrine. Right. So we have some parameters and our brain is thinking and we are trying to make the right choice. But now, if I give you the same numbers, but cardiac index drops, global endostolic volume is low, PPV 15%, we learned about the threshold, and lung water 4, which is normal. What is the gut feeling now? Dobutamine. Anyone for fluids? Fluids, yes, it's a fluid academy, so we want fluids. We asked colleagues of ISICEM, and you see majority fluids, but some are thinking norepinephrine, dobutamine, so medicine is not a clear science. There are many ways to treat the patient, but here, because of the PPV, I would say patient is probably fluid responsive. We should do the passive leg raise to be sure and so forth, but fluids could be an option. Now, the same numbers, but the only thing changed is the global end diastolic volume index, which is the preload, which is your venous return, sort of speak. So it's higher, but it's still normal. What do we do? Everything is the same. Patient is probably fluid responsive. If we ask the colleagues, you see now there is a shift because they are thinking filling is better, cardiac index is low, let's give dobutamine. Would be an option, but the PPV, I think, is more important in relation to the passive leg raise. If the PPV is trustworthy, so the patient needs to be in regular sinus rhythm, a tidal volume above 6 ml per kg, no spontaneous breathing, no right heart failure, no abdominal hypertension. There's a lot of limitations, but I think here, if the passive leg raise is positive, fluids. So now we change a little bit. PPV 20, even more. Fluid responsive, maybe, but the long water is 20. What shall we do? Who's for fluids? Well, let's see what the colleagues did. They don't know. A bit of everything. Yeah, here you could say, well, cardiac index is low if there is a lactate. It's a therapeutic dilemma. We know the patient is fluid responsive, PPV is high, volumetric preload is still at the low hand side, but the lung water is 20. So you know that when you're giving fluids, you're gonna flood the lungs further. So he may survive with a good cardiac output for a while, and he may die because of refractory hypoxia and no tissue oxygenation and cardiac arrest. So this is a therapeutic dilemma because 2 treatments are justified and we need to make the right choice. Now, if we change here and we increase the volume further, we lower the PPV, so no fluid responsiveness, well filled, lung water already on the high-end side. So now here everyone says we need to support the heart. There is no place for further fluids. So I think you follow the reasoning, why we make the decision and we choose. So now I need some participation of everyone. We try to identify the main determinant for different types of shock. So, hypovolemic shock. Blood pressure in O is low. Heart rate probably high. And cardiac index low, because otherwise we are not talking about shock, which is usually cardiac index below 2.5. So the main things is CVP, low, wedge, pulmonary artery occlusion pressure, okay, resistance, high, SCVO2, maximal extraction, so low, oxygen extraction, high to cover. Okay, perfect. So hemorrhagic is just the same because it's also hypovolemia, but now it's the blood loss, except for septic. So the patient is still in shock. CVP. Low. Wedge. Low. Resistance. Vasoplegia. SCVO2. High because there is a diffusion problem and oxygen extraction is low. Okay. Moving on, the sepsis with the ARDS. CVP. Silence. I don't know, can be anything. Low, normal, high. Yes, okay, but you can have a normal heart, but still capillary leak in the lungs, so it can also be normal, the wedge the same. Resistance. Okay, because it's sepsis, but you know the late stage may resemble a cardiac failure. SCVO2, well, you see, it's difficult. It's difficult to identify ARDS. Cardiogenic, CVP, high, Wedge, high. Resistance, high. SCVO2, low. Extraction, high. Okay? And now with the last one, the obstructive one. CVP, high. The obstruction is between right and left, like pulmonary embolism. CVP, usually higher than the wedge. And the resistance, SCVO2, extraction, same. Okay? So here we have the major patterns that we can occur. Now we need to identify what is the hallmark. The hallmark of hypovolemic shock is preload. At the time that we put the SWAN, and I saw that many of you still put the SWAN, so wedge pressure is the best estimate for preload. What is preload? What is preload? Yes, but how do we measure it? How do we define it? End diastolic volume. Are you sure? The definition of preload is the stretch between the actin, the myosin complex at the end of diastole. Okay, that's a good definition, but what do you do it at the bedside? You can use left ventricular end diastolic volume. It's difficult. You can use as a surrogate left ventricular end diastolic pressure. It's difficult. You can use as a surrogate left atrial pressure. When I was in training, the CABG patients had a direct line in the left atrium. If you don't have that as a surrogate, you can have the pulmonary artery occlusion pressure. If you don't have that, you use CVP. So there's a lot of assumptions. Sorry? Yeah, you can use ultrasound. Okay, good. But it's an intermittent measure. The wedge also fully agree. Cardiac ultrasound, absolutely. Look at the volumes. But by definition, it's a stretch. So the wedge here would be closest to left ventricular end diastolic volume by assumption. Septic, what's the hallmark? Vasoplegia. Vasoplegic shock. Septic and ARDS, what's the hallmark? I don't know. Something, but difficult to tell. Difficult to diagnose ARDS. Probably they have hypoxic pulmonary vasoconstriction, they have increased pulmonary artery pressures, they have increased wedge, could be, but not necessary. Cardiogenic, the hallmark there is the heart. So if you have a low cardiac index, two things, the heart is empty or the heart cannot pump. There's a failure. A failure in the pump is the hallmark. And for obstructive, most important one, CVP. So the CVP that is high because of the pulmonary embolism or whatever the cause. Okay. Now, sorry?
CVP as hemodynamics only.
There, yes, for pattern recognition, not for preload or venous congestion. Yeah. Now, I see, yeah, initially it was in the sepsis guidelines, 8 to 12, then they moved it, but I think CVP is important, and we should, again, measure it, if possible, continuously, before and after fluids, because it can help you to yeah, but it's intermittent. You can have the CVP continuously and see. I'm a fan, especially for the later stages of resuscitation and for evacuation. Yeah. So we saw there were some difficulties to discriminate because usually we don't have the wedge. We could use ultrasound. So the question is, if you would have PICO, would there be other parameters? So if it's hypovolemia, volemic preload is low, PPV is high, lung water initially normal, and pulmonary vascular permeability is okay, and the same for hemorrhagic. What happens with septic? Septic shock, they may have low filling, fluid responsive, and initially a normal lung water unless it's a pneumonia and ARDS. What for ARDS? What's the hallmark there? is that the lung water increases and the pulmonary vascular permeability increases. And for cardiogenic, the volume will increase, the preload, no fluid responsiveness, and a slight increase in lung water, which is hydrostatic pulmonary edema. Whereas in sepsis, it's a hyperpermeability pulmonary edema. And then for obstructive shock, this can go in all directions because you can have valvulopathies that may change the thermodilution signal. But if I would highlight volumetric preload as preload parameter, hypovolemia, the lung water in ARDS, in cardiogenic shock, the high volumes and the hydrostatic pulmonary edema, and in obstructive shock, usually you see high volumes because transit times are low and the thermodilution curve, the transit time is high, multiplied by cardiac output, gives high volumes. So this will help you to determine at the bedside what's the problem, and sometimes it's a mixed problem. You can have a patient with heart failure that has a septic shock. So now let's show you some transpulmonary thermodilution results of virtual patients. So you connect it to the monitor, you have continuous arterial pressure, it gives you blood pressure, heart rate, CVP if you measured it, and then we need to do a calibration. You enter the CVP for the continuous vascular resistance. The device tells you to wait until there is a stable temperature, and then you're gonna inject 20 cc of ice-cold bolus. So then you see normally your mean appearance time before the bolus gets to the picocatheter is about 5 to 10 seconds. There you have the thermodilution curve, which is quite small, so cardiac index will be high. Or not, here it's 2.5. So with these numbers, we have a lung water of 4 is normal, PVPI normal, cardiac index low, volumetric preload low, it indicates. Global ejection fraction, it's 4 times the stroke volume divided by the global endostolic volume. So it's like you have on cardiac ultrasound, you have left ventricular end diastolic volume, you have the stroke volume, then you have the left ventricular ejection fraction, which is about 55. For the right ventricle, it's about above 45, and for the global, it's above 35 to be normal. So if you look at these numbers, with a PPV that is high, volemia low, lung water okay, what is your take? And a temperature of 39. What's the problem? Septic shock with hypovolemia, volumetric preload, and probably fluid responsive. This is another patient, so you see the lung water is 12, global endostolic volume 910 is increased, and PPV is 5. So with an SVO2 of 50, what would be the take here? This more looks like, sorry? Cardiogenic. So the cardiac index is low, the volume is high, there is a bit of a lung water, could be hydrostatic pulmonary edema. Why? Because the PVPI is not above 3. It's only hyperpermeability if a PVPI is above 3. And there is maximal oxygen extraction. So here we did another intermittent measurement, I think, normally. Or maybe not. No, there's not much happening here. Okay, so let's move on. I think that was it with respect to pattern recognition. What we also do on big IFAP meetings is that we really have a simulator here with a mannequin connected to a pico monitor where we can guide the scenario of septic shock. And we do this together with Getinge. And I think sometimes they have this kind of sessions. We had one in Dubai recently in November. So this is also very, very interesting. It's a 2-day simulation lab. What's the time? 3:32. And we have for this session normally till, no, it's coffee break now. Eh? It's coffee break, eh? Yeah, time goes too fast. Is there any burning question? No? So we have a coffee break, and then we will have the case presentation by Abdulaziz, where we will go through the ROSE model from resuscitation to evacuation, and then Professor Hidalgo will have the closing lecture and then the exam and the group photo. Okay, enjoy the coffee break. We are back in 20 minutes, but that is 20 minutes. That is, 15 to 20 minutes. Okay, enjoy the coffee.